I want to offer a special welcome to those of you joining us for QI Power Hour for the first time. This is Dennis Kendall, the Acting CEO of the Health Quality Council. QI Power Hour is a free monthly WebEx offering hosted by the Health Quality Council here in Saskatchewan that provides opportunity for colleagues across healthcare as well as other industries to hear from local and national improvement experts on a variety of quality improvement related topics. Just a reminder that following today's session, a recording of the event will be posted to our HQC website for you to share out with your colleagues who are unable to join us in person today. And we also invite you to check out recordings and presentations of past sessions on demand at the address listed on your screen. While you are on our Health Quality Council website, we also invite you to sign up for our distribution list to ensure you receive regular invites to all of our upcoming QI Power Hour sessions. Over the last number of months, we're delighted to see how QI Power Hour has continued to spread throughout our province, within our provincial healthcare system, as well as to those in other organizations in Saskatchewan who have an interest in quality improvement. We've also begun to see spread to other organizations within Canada and even abroad. So again, welcome everyone to QI Power Hour. Before we get started, I'm going to turn it over to Chelsea Swartz to remind folks of the different ways they can contribute to today's session.
Thanks so much, Dennis. So the first feature that I want to highlight is the annotation function. So you can access this function by clicking on the scribble icon on the left-hand side of your screen. This should bring up an expanded menu on the left side of your screen where you can then select the arrow icon. So let's play around with using this tool. Our first question is to let us know where you're joining us from today. Great. Looks like we have some people joining us from the middle of the Hudson Bay, which is very interesting. Oh, great. Look at this. We have some good spread both across our province, but it looks like we have folks joining us from coast to coast today. So that's very exciting. Looks like everyone has a handle on that. That's great. Thank you so much. Welcome to everyone. The next feature I want to highlight is going to be a very important one because it's going to be the one that we're going to make the most use of in today's session. So this is the chat function. So some of you may have noticed that the WebEx interface has been updated, so it looks maybe a little bit different than what you've come to know it as. So in this new world of WebEx, in order to access the chat function, you can click on the message bubble that is now at the bottom of your screen. So this is where we're going to funnel in all of our questions and comments and ideas throughout the presentation. So I just like to pause here and make sure that everyone has found the chat function. So if you could put into the chat now the organization that you're joining us from this morning. Great, we have some folks joining us from the Saskatchewan Health Authority, New Brunswick, Regina area, Island Health, University of Saskatchewan, New Brunswick, Saskatchewan Registered Nurses Association, Central Health in Newfoundland. Great. We have some colleagues in Manitoba. Fantastic. Looks like everyone has found that function. That will be a great one to make use of throughout the presentation. So we welcome you to put your thoughts and comments and questions throughout the presentation into the chat. And we encourage you to send your comments to all participants so that everyone can join in the conversation. Finally, if you are a Twitterer, we encourage you to share out your learnings this morning using your Twitter account. You can use the hashtag QI Power Hour and the handle HQCSAS for today's session.
So for today's presentation, we are delighted to welcome a team of 4 presenters from the Health Authority in Saskatchewan and the Saskatchewan Health Quality Council. Today's presenters include Suann Laurent, Chief Operating Officer with the Saskatchewan Health Authority, and prior to her current role, Suann served as President and CEO of the former Sunrise Health Region. Sharon Garrett, who is currently Vice President, Integrated Urban Health and Chief Nursing Officer with the Saskatchewan Health Authority, and previously Sharon served as the Vice President of Integrated Health Services in the former Regina Qu'Appelle Health Region. Adrienne Danyliw, Project and Policy Consultant with the Health Quality Council, and Kyla Avis, Project Consultant with the Health Quality Council. Today's presentation, we will first have Adrienne and Kyla share some of the history of the ED Waits Initiative and the simple lessons they've learned through their work supporting this initiative. You'll notice the word simple is in quotation marks because while they are simple concepts, they are quite complex to address. After that, Sharon and Suann will share how these lessons have been and are being applied across Saskatchewan now, and a bit about how the SHA now has the opportunity to apply these lessons in a single coordinated health authority. We'll then have a brief Q&A session following the presentation. Thanks to the four of you for joining us here today. We're excited to have you here and to have the opportunity to learn from your experiences. We'll now turn it over to Kyla and Adrienne to kick off today's presentation.
Thank you, Dennis, and thank you everyone for joining us today. We are presenting to you 10 key learnings that came from the Provincial Emergency Department Wait and Patient Flow Initiative. And like Dennis said, we're calling them simple, in quotes, not because they're easy, but because we wanted to take this time today to sort of synthesize the years of work and learning into key concepts that people could easily understand and communicate regardless of where you work in the system. Emergency department waits are not an easy fix, and there is no magic bullet. But by all of us being on the same page and understanding which direction we are moving into, it helps us align our ideas and actions to accomplish the system-level changes we need to improve this issue in Saskatchewan. We hope these 10 ideas will lend itself to a narrative you can use to engage those around you to keep us moving in the right direction. First of all, I want to begin, before we get into the lessons, I just want to take a moment to thank all of the people who have contributed to this work over the last number of years. The Emergency Department Wait and Patient Flow Initiative was led by our colleague Graham Fast, who now serves as Director of Acute Medicine in Saskatoon, and I believe he is joining us today on the webinar. So Graham, if you can say hi in the chat, it would be great to see you. Graham's leadership brought together a number of individuals who contributed so much to the project, from physicians to patients and family members and researchers and consultants like me. It has personally been a great privilege for me to have worked with all these people over the years, and we thank each and every one of them for their past, current, and future contributions. For those of you who might not be aware of our journey in Saskatchewan, I just want to give you a brief background on our Emergency Department Waits and Patient Flow Initiative. It was set up by the Ministry of Health and located within the Health Quality Council after a 2014-15 health plan goal that stated no patient will wait for care in the emergency department by March 31st, 2017. In 2015, that goal was revised to a 60% reduction in emergency department wait times by March 2019. Between 2014 and 2016, the initiative engaged with stakeholders, implemented some provincial lead-out strategies like alternate level of care data collection and interdisciplinary bedside rounding, and made some investments in pilot initiatives such as community paramedicine and seniors care teams in the community. The team also sought input from patients and families and conducted an in-depth literature review to explore interventions that had the most potential to improve wait times in Saskatchewan. One of the critical strategies employed was health system modeling that allowed us to test different interventions on the wait times in our various emergency departments in order to understand where the best investment of resources may be. In 2017-18, the concept of connected care was put forward and adopted by both the Ministry of Health and the Saskatchewan Authority as a priority strategy to improve wait times, patient flow, and the overall care experience for people in Saskatchewan. If you would like more information about the modeling or the history or how we got to the connected care strategy, there's 2 previous QI Power Hours that you can view on the website. Both of these webinars will sort of fill in the gaps of what we aren't able to cover here today due to our time constraints, but they're very good webinars for some more background information. As many of you on this call will attest, meaningful improvement at the system level is very difficult to achieve. But we are starting to see some signals of improvement, especially in Regina, which are very promising. In Regina, the 90th percentile for time waiting for an inpatient bed has gone from 29.5 to 26 hours, which is about a 12% reduction. We also know there's been signals of improvement in ambulatory care-sensitive conditions, hospitalizations, condition hospitalizations, and readmission rates. So we feel pretty confident that something is happening in Regina, and that's signaling a system-level improvement, but there's more to understand and learn provincially. And that's where we find ourselves today, at this crossroads. Go to the next slide. Yeah, the crossroads of Strategy Street and Implementation Avenue, which I quite like to situate ourselves here today. We're starting to have a conversation with the system about where to from here, knowing what we know, seeing what we've seen over the last number of years, where to now. We are positioned to take work from the ED Waits and Patient Flow Initiative and put all hands on deck to start implementing some of the things we know will get us not only to improve wait times in the emergency department, but better, more seamless patient care across the province. As a system, we want the shared goal to really be centered on patients getting the right care in the right place at the right time by the right provider.
So thanks, Kyla. This is Adrienne, everyone. Welcome to the call. I'm very excited to present here today. So the initiative was responsible for providing evidence to the health system that would lead to wait time improvements and improve patient flow. During the process of research, consultation, and collaboration with leading experts in Saskatchewan and around the world, we found repeated themes, ideas, concepts that are supported and used to address the same issues we have here in Saskatchewan. One of these central messages was the need to reduce reliance on hospitals in order to improve the health of our system. And then wait times in the emergency departments will decrease. This central theme is valid in Saskatchewan, and we know this because we are using our own health system data through a computer simulation model to test various scenarios on what will reduce wait times in the emergency departments. And the results consistently point to reducing hospital occupancy. Around this central theme of reducing reliance on hospitals are 10 other key concepts and evidence that are important to share and focus and discuss. These are critical elements that will contribute to transforming our health system to meet our care needs into the future. As with anything, the devil's always in the details, but as broad concepts, these are the areas that we need to focus on provincially to decrease our reliance on our acute care system and strengthen other areas of our health system. So as Chelsea mentioned, we want to hear from you. It's not just about you learning from us about what these 10 lessons are, but we also want to support you to learn from each other. So with each lesson that we share, we want you to use the chat function to talk about who's doing what where. Share the work that's happening in each of these areas, who is leading the way, and you'll also see us hyperlink a number of resources throughout the presentation. So feel free to ask questions on the chat as we go through. So without further ado, Lesson 1. Lesson 1 is about team-based care, which is the foundation of the Connected Care strategy. We need to accelerate the pace in which we're advancing team-based care in all healthcare settings, not only focusing on team structure, but how teams work together. The Primary Healthcare Framework Report in 2012 highlighted the need for team-based care, and the literature strongly supports that high-functioning teams provide high-quality care. But it's not just about putting people together, it's about how well they work together and how well they trust each other. This sketch note from the UK highlights 10 things that fabulous teams do. High-functioning teams work well together, manage conflict, have a shared purpose, and lead collaboratively. One of the key factors is psychological safety, as it's the #1 component of any high-performing team in every industry. There are a number of tools and resources to explore if you're ready to advance your team. One is a Saskatchewan Design Team Development Tool, which allows teams to assess how well they work together and provides a framework for team discussions on how they can continue to develop and improve. Also, the British Columbia Patient Safety Quality Council has recently released a toolkit called ATIC, which stands for Activities for Transforming Teams and Igniting Change. This provides teams with tools and activities to help them build a sense of teamness. So we want to hear from you. Where do you see fab teams in Saskatchewan or elsewhere? What makes them fab? Is anyone doing work specifically on building psychological safety within their team or building relationships with new teams? I'll let you add into the chat and I'll pass it over to Kyla.
So while you're contributing about where you see fabulous teams in Saskatchewan and elsewhere, I want to talk about the reason of why we need these teams to be working together effectively. And that is so that we can deal with the growing issue in our healthcare system, which is around an aging population and increasing complexity related to multimorbidities. Our health system was set up at a time where people didn't live as long and didn't deal with the complex combination of health and social issues we are seeing now. For example, it's becoming increasingly difficult to set up disease-specific clinics when people are struggling with more than one chronic disease and possibly a myriad of unique social issues. The silos that we originally created in our health system are failing patients who no longer cleanly fit into these separated care services, and this new type of patient calls for a new type of care model. What we now have is a system that often feels fragmented from the patient's perspective. To reduce emergency wait times, we need to focus on reducing the fragmentation in the system for a more seamless and coordinated care experience, which will serve to reduce readmission rates, reduce hospitalizations for ambulatory care-sensitive conditions, which are considered preventable for conditions that could be managed in the community, and reduce unnecessary hospital days where care in the community is not available or accessible, and ultimately reduce the capacity in our hospitals. I heard a statement from the president of the Canadian Nurses Association that week that talked about the dehospitalization of our healthcare system, and I think that's what we're talking about now. So Saskatchewan has room for improvement in all of these indicators. One of the strategies being employed in a number of health systems around the world is what we're referring to as intermediate care teams. And intermediate care teams aim to close the gap in services between traditional services provided by GP or home care and hospitals. This model that we see on the screen is from the former Regina Coppell Health Region, which shows the number of services that they've added in recent years to bridge the gap between their community services and acute care services, such as seniors house calls, community IV therapy, community paramedicine. Many of these new services operate 24/7 and address the community's needs, working to reduce reliance on emergency departments and hospital care. And these kinds of programs are being set up all over the province, and this is what's most exciting about the connected care strategy from my point of view. So we'd like to hear more about who is doing what with intermediate care teams in the province. We know Regina isn't the only one working on this, so please share with us locally and nationally where this work is happening so that we can understand what work is happening with intermediate care development in your neck of the woods.
So lesson 3, we're going to make it a little bit interactive. What do you think is a low-cost and safe and effective way to reduce how long people stay in hospital? And before you take too long to answer, the answer is mobilization. And this is really important because our health system modeling, which essentially allows us to use our local data in Saskatchewan to test virtual scenarios and see what impact it would have on wait times. So this modeling has shown us that we need to find ways to reduce hospital occupancy. And one of the ways to do that is to reduce how long people spend in hospital when they no longer need to be there. The challenge is, for some people, especially older people, just being in hospital means that they're bedridden and experience functional decline, which then they take longer to recover. One quote-unquote simple idea is to keep people moving when they're in hospital and prevent functional decline. In Ontario, they did a multi-site study with over 12,000 patients and found that a 10% increase in mobilization resulted in a 3.45-day decrease in length of stay during the intervention and a 6.1-day decrease post-intervention. And this is critically important because mobilization in hospital is low, at a median of 43 minutes per day, according to some studies. Without mobilization, elderly patients lose 1 to 5% of muscle strength each day in hospital, and immobilized seniors are 6 times more likely to be discharged to long-term care instead of home. Also in Ontario, they developed a program called Move On, which stands for Mobilization of Vulnerable Elderly, which essentially has 3 components. Encourage mobilization at least 3 times a day. Mobilization should be progressive and scaled, and mobility assessments should be completed within 24 hours from admission on the unit. So now, using our local data in Saskatchewan and our health system model, we were able to look at what if we were to achieve the same results in Saskatchewan as they did in this Ontario study with the Move On program. And what we found were amazing results in the potential to decrease time waiting for an inpatient bed. As you can see here, showing the results for St. Paul's Hospital, where the wait time target is way at the top of your screen there, showing the time waiting for an inpatient bed at the 90th percentile at about 9 hours. when you compare that to, in comparison, the results for implementing high-quality care transitions gets us to about 6 hours, and the Move On program would get us to about 1 hour. The reason for this dramatic impact, and have to confess, the impact is the greatest at St. Paul's Hospital compared to other hospitals, is due to the reduction in functional decline, and therefore the length of stay amongst older adults. The thing is, this work can easily, quote unquote, be implemented by teams. And mobilizing patients is taking off around the world in the form of a campaign, #EndPJParalysis, which is about getting people out of their hospital gowns and into their own clothes. This helps to change mindsets about what you can and can't do in the hospital and helps to maintain mobility. This sketch note is from the UK, but I know this work is taking off in Alberta too. We've also heard that NPJ-paralysis work is happening around Swift Current. So we hope this idea will continue to spread, and we want to hear from you. Who's doing what to increase mobility in hospitals across Saskatchewan?
The fourth lesson is related to the strategy of connected care, which is really continuity of care. And you'll hear more about that from our co-presenters from the Saskatchewan Health Authority after we've presented these lessons. But there's 3 types of continuity that needs particular attention in our healthcare system. Relationship continuity, which refers to maintaining the therapeutic relationship between providers and patients. Management continuity, which is about shared understanding of patient goals and the plan to achieve them. And information continuity, which is about the availability and use of information on past events and personal circumstances that supports appropriate patient care. And I think we're going to hyperlink a report from Alberta Health Services that was done in 2013 that really speaks to this issue of continuity of care in our healthcare system, and it's definitely worth a read. So shout out to our colleagues in Alberta. The health system modeling we employed looked at many different ways to impact our time waiting for an inpatient bed. We found that the waits are a direct result of our hospitals in our province being too close or over capacity for much of the year. As a result, the most impactful strategy we modeled focused on reducing length of stay and readmission rates of hospitalized patients. If our hospitals could operate around 80% capacity instead of 100% or over, we would be able to achieve our provincial wait time goals. The framework we adopted and adapted with permission from the authors was created by a team of U.S. physician researchers who looked at the important components of successful transitional care programs for readmissions. And I think maybe some of those authors are joining us today, so if you are, please say hi on the chat so that we can say hi back. But this model was adopted from them, and it was called, what they called it was the Ideal Transition of Care Framework, and what we're calling it is our High Quality Care Transition Strategy. The domains of the Ideal Care Transition Framework align nicely with our priorities around continuity of care for improved transitions between hospital and community. We also highlighted the importance of high-performing teams in community and hospital as foundational pillars to the framework, as well as the addition of the functional decline prevention due to its high potential to decrease length of stay. We have a document that dives deeper into each one of these domains a bit more, and it's available on our website, and we'll link it to the chat as well. But really, this is what the main focus of the Connected Care Strategy is, and one of the key learnings out of this, the Patient Flow Initiative. So please tell us who is doing what where around connected care, high-quality care transitions, any of those domains that we shared in the bridge. We're very interested to hear what work's going on. We know there's a lot of it, so please share with us what you're working on.
Thanks, Kyla. And I realize that we're probably running through many of these lessons pretty quickly, so we appreciate your ability to listen and contribute to the chat, as well as take in some of the messages from what we're presenting. We'll certainly provide a summary of the chat through our HQC sites after this, and the presentation will be posted online for you to review if needed. So lesson 5 is around opportunities to improve in the emergency departments. So as you've heard, major gains on improving patient flow is by reducing hospital occupancy. Hospital factors in the green box of this diagram. But that doesn't mean that there isn't ongoing work and important work happening within the emergency departments, and that's within the pink box here. A recent report from the Manitoba Centre for Health Policy on the bottlenecks in the Winnipeg emergency departments highlighted that factors within the emergency department are also important and impact wait times, things like lab, diagnostic imaging, and consultation. So we're using, again, our health system model to understand which factors within the emergency departments will have the most impact on reducing wait times. But even before those modeling results are ready, there's alignment with this work with choosing wisely, with toolkits available on decreasing unnecessary lab testing within the emergency department.
Lesson 6 is about the important role physicians have in the redesign of our system to improve patient flow in our emergency waits. The active leadership of physicians in our system cannot be understated. We know that every high-performing healthcare system in the world has active physician leadership at the forefront of their improvement initiatives. And with the recent amalgamation into one health authority, you can clearly see this was a priority for our province. We have some fantastic physician leaders situated at the highest levels of our organizational structure and cascading physician leaders right down to the local level. We know their work and leadership in the months and years ahead will be critical to achieve our health system goals, and we are very excited for what the future holds. And Saskatchewan is a very exciting place to be. So for those of you who are not here, you really must come and see.
The lesson 7 is around the need to integrate our physical, mental, and social support systems, because these things don't exist separately within us as people. For example, you can't get home oxygen if you don't have a home. You can't have a low-salt diet if you don't prepare your own food. And you won't take your pills for your medical problems if your psychiatric problems are untreated. In Saskatchewan, there's work underway to bring people together to work across sectors, and the hub tables is a great example of that. This work is critically important, as we've recently demonstrated in Saskatchewan the link between mental health, unstable housing, and high-cost healthcare use. Our own researcher here at the Health Quality Council, Maureen Anderson, is the lead author on the study in the Canadian Journal of Public Health and shows that those people with mental health challenges who did not have stable housing were more likely to be high-cost healthcare users as compared to clients with more secure housing. So again, we want to hear from you. Where else is cross-sectoral work happening in Saskatchewan?
So lesson 8 comes from my background as a registered nurse, and even though I haven't practiced bedside nursing in quite a while, I still recognize the clinical importance of vital signs. Care providers use vital signs on a daily basis to determine how patients are doing, if interventions are working or not working, tweaks to care plans, and to make informed decisions. Now, as a quality improvement consultant, I see system metrics as our system's vital signs. How are we doing? What's working? What's not working? What adjustments do we need to make that will allow for our healthier system? In 2015, steps were taken to develop a new vital sign for the system, one that maybe wasn't a high priority for system leaders at that time. For years, many believed patients designated as alternate level care, or ALC, were just those waiting in hospital for long-term care. Everyone knew this was an issue because it was not an ideal place to keep an elderly person as they waited for placement. But in actuality, ALC is a much bigger problem than what we knew at the time. What we have worked to do in the initiative over the last number of years was to raise awareness that the ALC designation can actually be ascribed to any patient who is occupying a bed in a facility but does not require the intensity of services that care setting is providing. Though this does include patients waiting for placement, it also includes patients who are waiting for treatment that could be provided in their community, such as PT, OT, or a diagnostic test, or for equipment to be installed in their home, etc. The provincial database shows that we have about 428 patients each month waiting in the hospital that do not require the level of service the hospital provides, and the average wait time for an ALC patient in our province is 17 days. By understanding our ALC data better, it helps us to inform the kinds of programs, services, resourcing, and staffing that needs to be applied to reduce the number of ALC patients waiting for hospital and address hospital overcapacity. The great thing is that many of the services not only support patients to come out of the hospital in a timely way, but can actually prevent them from going into emergency departments or getting admitted as well. The new community health center in Market Mall in Saskatoon was specifically designed to reduce the number of ALC patients from that area of the city. We need to continue to work more on understanding the needs of hospitalized patients so that we can prevent their admission and bring them back to the community as soon as it is safe to do so, and prevent them from relying on hospitals when the care they need could safely be provided in the community. Again, this helps us focus the right care at the right place by the right provider at the right time and requires a new focus on strengthening our community care services.
So lesson 9 is about the need to shift the conversation, both inside and outside of healthcare, about how we want our healthcare system to look into the future, and social marketing can help with this. For example, we can learn from Mount Sinai in New York as they launched a marketing campaign in 2016, promoting their renewed emphasis on keeping people healthy, caring for them at home as much as possible. They promoted mobile acute care teams, preventable admission care teams, health promotion, and wellness. We're doing very similar work in Saskatchewan, and we should think about how we can shift the paradigm by shifting the conversations.
And finally, last but not least, is really the lesson that's really focused on patient engagement and hearing our patients and understanding what matters to our patients. So in 2009, Saskatchewan conducted an extensive patient first review, and one of the studies that was completed by KPMG for the Ministry of Health was a report on the patient experience component of the patient first review. The review stated that these 5 key things were the things that patients wanted: fast access to needed services, effective case management coordination, good two-way communication, providers who show they care, and recognition of the unique needs of the underserved populations and regions. The question now is, have we moved forward enough on these key areas in the last 10 years? What areas can we continue to work on to improve these things? We feel that focusing on continuity of care, care transitions, high-performing healthcare teams will allow us to take a significant step forward in providing what patients and families want and expect: faster access, better coordination, communication, care and concern, and understanding their unique needs as individuals and communities. At the end of the day, it's really making sure we know what matters to the patients and that they know that that matters to us. This is one of my favorite tweets that shows exactly how simple this task can be in any setting. So with that, I will hand it over to Suann and Sharon to tell you more about the directions and planning that's going on with this work in the Saskatchewan Health Authority. Thank you very much.
I just want to talk about what a great opportunity it is for us to actually be one health authority now, and our ability to help drive that change throughout our entire system. So we see as one health authority that we're going to have more provincial integration, we're going to decrease variation, increase quality and safety, and decrease cost. And we're going to do that through all of the work that you've heard about across our entire system. One of the other things is that it really reflects well with our vision as a new health authority is healthy people and healthy Saskatchewan. And our mission really is about all the things that you heard about being talked about this morning in terms of working together to improve our health and well-being every day for everyone. And that mission actually drives us through to our strategic plan, and one of our main goals is the connected care strategy, but actually having connected care for the people of Saskatchewan, improve team-based care in communities, and reduce reliance on acute care services. So we're really moving towards a health network approach in all of our 6 areas across our entire province, and it's everyone's work and in everyone's work plans and operational plans now across our health authority to move towards that and everywhere based on Regina's work. And really, when you look at those 4 bullets under the goal there, the other one that I would add is it's really about system flow. It's everyone's job, and that it's from long-term care all the way upstream to people looking after themselves and having a healthy health status in the province to actually help. We all own a part of this to not end up in acute care, and really talking about those healthy lifestyles as well. So with that, I will turn it over to Sharon and just say it's just really exciting to be able to integrate that all as a health system, and there's lots of work ahead of us, but we have the right team to do it.
Thank you, Suann. This is Sharon Garrett, and I've just been kind of keeping an eye on the chat as we go and seeing a lot of very good examples from across the province and other sectors about the work that's underway, and it's just really exciting to look at all that work and see that, that we are doing a lot of things already across the whole system. As in my role as the Vice President of Integrated Health, I don't know if I advance the slides or if someone can go to the next slide for me. So I'll just ask for that. And what I want to flag, so sorry, I'll just talk about some of the story, a bit of a story more about the Regina area. And this isn't because I think that Regina is the only focus of the system, but it's starting, the model is starting to mature in Regina, and the approach is starting to actually integrate all of the things together, and I think that is the vision that we are focused on moving forward across the province. So people may know that we in Regina had built care teams and have integrated those teams in the community in an area. So public health, home care, the assessor coordinators that align with them, and all of the providers are co-located in areas in networks or in teams together, not everywhere yet, but those teams we've seen real significant progress. They do a huddle in the afternoon where they talk about the challenges with clients in that area. At that huddle, that there is actually a way that they're monitoring patients that have gone to hospital in order to determine if they can pull them back to their team in the community. And they're also monitoring, you hear conversations about people that may have a potential to go to hospital and how they can keep them out. I think how we're starting to evolve those teams is the integration with the physicians. So that was slower in Regina, but what we're now seeing is involving the physicians as leaders and integrating with the care teams in the communities, that the physicians are part of those teams and part of those conversations with some of the teams now. They're able to work with physicians in their practice, and if a physician has a concern about someone in the community that they can't get out to, the care team in that area is going out, assessing the individual and connecting with the physician on the care plan. So we're starting to build that integration not just with our employees, but with the physicians. We also have a dyad connected in with the network physician, and I had the great opportunity to talk with one on Friday, and that physician as a leader has gone out with the home care team to understand what home care services are like in the community and understand what the challenges are so that he can help support how we interact together in a meaningful way. So that's involving physician as a leader with that care team. In the hospitals, you've heard about accountable care units, which is the team we've built as a unit function in the hospital. How we're starting, and there's 4 pillars to that, which I won't remember as I'm talking here, but one key pillar is that the cyber rounds, where the physicians and team round with the patient at the set time of day in a set process, very standard process each day, and that the families and patients know what that time is and can expect to be involved in those rounds and integrated with that team. And we've had significant impact from the accountable care unit and the team, again, working together. But what I've started to see advance is the physicians as leaders of those accountable care units are now coming out to talk with the teams and understand what's happening in the community huddles, to talk about how we now bridge that bridge of the high-quality care transition and how we transition more effectively between an accountable care unit in the hospital and an integrated team working in the community. So we're starting to evolve it into how we build those connections. I also had the opportunity at the end of last week, there was a group of physicians and working with our team on how we manage diabetes in Regina area. So there was ER physicians, there was family physicians, there was our integrated teams in the community. Some of those are intermediate care teams. And what they were talking about in the conversation, they were passionately engaged in the conversation about how they work together across that continuum in order to ensure better care for one of our chronic conditions of diabetes. And again, it's the physicians as leaders engaged in the conversations, but it's involving physicians at all levels, but it's working with the care teams that we have and building those connections across the continuum in one city. And the buzz was amazing, and to see how those teams work together. So if you think about the processes within the ER, they were talking about, we have information, we do this assessment, how can we link and communicate that back to the community here, but working with physicians in that. So just really starting to see the benefit of, we're building the teams, we're now starting to build the bridges between the teams, and seeing the value of how we build those things together. The other example I thought that's recently arisen for us, we talked about ALC, so in terms of aligning our measurement systems and what we're measuring and whether or not we know what the issues are. So the ALC information is very significant for us in terms of knowing and understanding some of the focus or work that we need to do now in our system. And we had a planning session yesterday in terms of what's our next 3 months worth of work, and it was very clear that executive directors of primary health care, executive directors of continuing care know and understand that they have a role in terms of working on all of the factors that we've seen come out of the data on ALC to ensure that they're considering how we pull and manage patients more effectively in other sectors rather than in the acute care sector. When we look at the processes within the emergency department, we know we have considerable challenges still within the RUH and St. Paul's Emerges in Saskatoon. And we worked with HQC using some of those modeling tools to really help us focus on what was some very focused work that needed to happen over in a shorter, within a year, in order to manage some of our challenges, knowing that we will be moving into a new ER emergency department space at RUH that doesn't have room for patients waiting to go up to the units to stay there for extended periods of time. So that modeling is just the value of that, and just the picture that you see when you try different scenarios and you see, oh, that didn't make any change. Oh, that didn't make any change. We still can't see the patients that we need to see. But you know what? If we work on the ALC together as a system and understand that's what will make a difference in the modeling, then we will free up the time and space for the ER to do their work. So we're all committed. We clearly get as a system, when you think of our strategy around connected care, that we are talking across the system. Our focus and our priority is in the primary health care area in terms of all across the province to ensure there's a solid foundation of services to support people at home and as close to home as possible, have episodes through our acute care sites, and then come back to home or to other services that are in the community to support people. So we're headed there, we're committed, we're starting to see some maturity of models in some areas, and as you've seen in the chat, we're seeing amazing work across the province in all areas. It isn't just about one place doing it well, it's amazing work happening across our province. I know there's lots of our team people on the line. If you have ideas and you want to bring them forward, if you're a frontline nurse, talk to your manager. If you're a manager, talk to your director. If you're a director, connect with your executive director. If you're a physician, find the leaders in your area. Talk to them about projects that you want to be involved in and that you want to engage in so that we can make improvements. Thank you. I'm going to turn it back to the team at HQC to keep us moving.
Thanks, Sharon. Hi, everyone. This is Adrienne. So I encourage folks to ask any questions through the chat. If you have specific questions for any of our presenters, please let us know, type the name into the chat of who you want to ask your question to. I do see that Tanya had a question about physical layout in the emergency department and how that impacts patient flow as well. And Sharon, you might want to jump in here too, but I was reflecting on some of the modeling work that we had done in partnership with your teams around the move into the new Children's Hospital from the emergency department, where we were able to take the planned floor plan, footprint of the new emergency department and put that into the model to really understand how patients would flow through there, given that there are limited spaces and different restrictions and just differences to consider going from the current layout to the new layout.
You know, I think you've said it. In the modeling of the move, you were able to implement or put in a number of factors. So some is when you move into sort of a more, the footprint is actually bigger, so there's more space, which makes for more walking, but it's organized in a different way, which creates some other challenge, or it just means you have to have different processes and different flows. So the modeling was able to take that into account and look at how are we using patient spaces, and you looked at the type of patients that were coming in and how they would flow through the spaces. And it was really helpful to understand how that would shift the work and what impact that would have for people, the staff and others coming into the area. It's a real visual, and I know that you have used that tool for other work in terms of the Children's Hospital and teams moving in.
And also at RUH, that was done as well.
Yeah.
Thank you. In looking at the chat too, it looks like there was some earlier discussion about information flow on our electronic systems to be able to support that across various elements of our healthcare system. So I know there's work going underway to help address that, and that's a bit of a gnarly challenge. I believe there's some work that's happening around shared care plans and developing that, even in establishing some of the processes for how teams work together in advance of having some of the electronic systems really be able to talk to each other. And I know there's some great work happening at 3S and through the EHR viewer to support some shared communication. And Sharon, if you wanted to, or Suann, if you wanted to add anything, any more specifics to that, that would be great.
No, we are working with eHealth as a partner. People will know that our systems don't talk well together. So even in our SCM is the electronic health record that we use in acute care, and we don't have one instance of SCM. We have at least 6, I believe. So that is some of our focus, and then people will also know that in the community we have electronic medical records in physicians' offices and in our primary health care sites that don't talk well together. There's connections to view things through the e-viewer, but there's been some really good conversations starting with SMA, the Saskatchewan Health Authority and eHealth and the Ministry of Health about how we take a more strategic view to those systems to ensure that they can connect, and that all of our team members, physicians, our integrated teams that are working in communities, and our team members in the hospitals can access information and ensure there's a good flow across the systems. But that will take time. You're correct on that. So we have some other tools we're looking at in the interim.
Thank you. I also see a little bit of discussion happening around structured interdisciplinary bedside rounds. So I know that is a core component of some of the work in hospitals in standing up the accountable care units. And from HQC's perspective, throughout the initiative, we developed a toolkit around how to evaluate and set up interdisciplinary bedside rounds. So that resource is available online for those folks who are interested in getting going on that. And as you can see, there's lots of people from across the province who have an interest in that area.
Okay, I can just see in the chat. I can see in the chat that some of the participants who are more knowledgeable about that are responding with answers, which is really helpful. Thank you, Kish, and some others.
So as you're thinking of some more questions, I think we'll encourage folks within the system to connect on a platform that we're testing called Slack. And it's an online platform to support these types of conversations that you're having on the chat right now in an ongoing way. So for those folks who haven't signed up yet, we'd encourage you to join. The link is there. If you have questions specifically for any of the presenters, you can certainly email myself or Kyla. Our email addresses are right there. And if you have questions for Suann or Sharon or in general about some of the work in the SHA, the best place to filter those to is to info@saskhealthauthority, and the person who manages that inbox will be able to redirect your question to the most appropriate person. With that, I'll pass it on to Chelsea to talk about the next QI Power Hour.
Great, thank you so much, ladies. There's been a ton of activity on the chat, so that's been fantastic to see today. I'm pleased to say that this has been one of our most well-attended QI Power Hours, so thank you everyone for taking the opportunity to hear about this great work that's happening. We invite you to join us for our next QI Power Hour session on Friday, November 23rd. We'll have Doug Campbell, who's a provincial improvement consultant here with the Health Quality Council, share his learnings and reflections in his work outside HQC. He has been undergoing citizen astronaut training, so you can join Doug on QI Power Hour to hear about Untethered Explorations Framework for Learning, how this framework supports accelerated self-improvement, and how it yields better teams. We also look forward to your feedback on today's session. You'll notice when you close out of WebEx that a survey will launch, and in the spirit of continuous improvement, we're always looking at ways to improve our offerings of QI Power Hour. So I'll just return to the Slack channel here. Again, we welcome our Saskatchewan healthcare system partners to join the continued conversation. We'll have Kyla and Adrienne both available for conversation on Slack. If you are having trouble getting set up, if you're bumping into any technical difficulties, both Caroline and myself under HQC WebEx will remain on the chat to help you troubleshoot through and help you get connected. Do we have any other questions that have come up?
This is Sharon. I see one there. Someone has asked, I'm curious about how the connected care strategy is socialized to the many structures and groups, and that's a really good question, because we recognize as we're trying to evolve the system that we need to do that effectively with patients, families, physicians, our staff, and others. And so some of the work that we're doing, as we've talked about the integrated teams, and some of the work that we will be doing more consistently across the province is health networks, looking at what those look like across the province and how the integrated teams work together in those networks. That work is being co-led with the Saskatchewan Medical Association, the SHA and the Ministry of Health, as well as the the Saskatchewan College of Family Physicians. So we're really, it's about the integration of leadership. We are also talking now about, we need to be talking about what our vision is and what our model is with more stakeholders, so that all groups understand kind of where we're headed and what our vision is. So it's a really good question, and we're looking at how we can do a lot more about sharing the vision and more conversation with all of the stakeholders that need to be engaged with us.
I think Suann, just to add to what Sharon's saying, I think it's really important and strategic to have that actually in the strategic plan and then rolling out through operational plans in the sector, but also we have lots of discussions with partners and communities and our networks to actually help roll that out and understand that it is a priority. So that alignment has helped us and also helped us keep on task with reviewing things every 90 days as an executive team to see where we're at.
Thanks, Sharon and Suann. I see a great question here from Kish as well on the chat. I don't know if you've had a chance to take a peek at that, but his question is around the role of team-based care training to enhance the competencies that make high-performing teams. The literature is abundant, but we're not yet explicitly promoting this to frontline staff, and what are some of the plans for the SHA to enable this?
That's a really good question, Kish, and I know the work that has been done in Regina was a lot of, you don't just start an ACU. There's a lot of work in terms of building the team and how that team functions together and builds to becoming a high-functioning team. And you're absolutely right. It's not just on an accountable care unit. We need to be building that expertise the competencies and how people work together, and that is a part of our planning as we move forward. So I can't tell you explicitly today that I know exactly what that is, but as we move forward with the strategy, that's a component that has to be a part of it, or we won't achieve success. So thank you for flagging it.
Thank you. Great discussions. Thanks to everyone for keeping the conversation going on chat. Like we said, a couple of us will stay online to continue to be present if you have questions. We do want to encourage folks to continue the conversation on Slack so we can continue to have that across the province and over time. So thank you again, everyone, for joining, and we'll see you next QI Power Hour.
Thank you all.